Just antimicrobials. Okay, great. All right, so good news and the bad news. The antimicrobials is a gigantic, long list of antibiotics and antivirals and very complicated toxicities and things like that. I'm going to try to keep it pretty simple because I think there's probably no place for asking a question about something that happened, once with vancomycin in 1973. So let's just keep it straightforward. And my hope is that you can kind of just remember the basics, this is what we expect to see, and this is the treatment. So the lecture will be a little bit of a kind of almost like a listy type of lecture, which I try to avoid, but there's no great way to group and split antimicrobials. So I'm going to talk mostly about, let's see, these guys. One, because they're specifically named in the CSPI manual, but also because they have specific toxicities and they're both clinically relevant and could be questions on the exam itself. Yeah, I know. The reason I say that, Amy, is because that, like, our Tox boards tends to have a thing where there's one case report from 68, but I don't think that they're going to get very picky with these guys. I think the more important thing is to remember sort of generalities. And, we'll get into the specifics, but penicillin seizures, and maybe what the dose is that required to do that. So let's just get into it. We'll go through each of these one by one, talk about some of the specifics. The first big group is aminoglycosides. The good news is there are no oral formulations of any of these. They're either topical, ophthalmic, or parenteral. We don't see a lot of topical or ophthalmic ingestions that are significant. So really what we're talking about with this group, and mostly we're talking about gentamicin, is going to be iatrogenic overdoses. So this is going to be people who gave way too much gentamicin by accident, by error, and even the Ortobra, maybe amikacin. But this is exceedingly rare. So I think from a clinical standpoint, this is something I would look up, if it happened. But from a test taking standpoint, two things to remember, and I try to kind of put my brain in like gentamicin and then think about nephrotoxicity and ototoxicity. So kidneys and ears. The nephrotoxicity is an acute tubular necrosis. And again, this is from either too much gentamicin or some reason why they're not getting rid of the gentamicin, and we keep giving them gentamicin and maybe not checking trough concentrations, and it accumulates. And that would usually be in. So I think of this as two groups. One, oops, we made a mistake. We gave a 10-fold dosing error in a kid, or we gave a pretty high dose and they developed, acute kidney injury or some other reason why their gentamicin concentration increased, and so they developed nephrotoxicity. So obviously the nephrotoxicity makes the toxicity worse. We get into this same thing with vancomycin. If the trough concentration is a risk factor for nephrotoxicity and nephrotoxicity decreases its excretion, then it's a little bit of a cycle. And so that becomes an issue. Ototoxicity is both vestibular and cochlear, so it's hearing loss that is usually permanent, although sometimes it does get a little bit better, and also vertigo and tinnitus, so not just hearing. The treatments are few and far between. There are, most of the time it is stop the medication, so that's not particularly, all of that gratifying. There's some evidence for N-acetylcysteine for decreasing ototoxicity. The studies are done with giving N-acetylcysteine when you're giving gentamicin. So it's not quite the same thing as treating, but because of this study. Sometimes we might recommend N-acetylcysteine. I don't think that'll make it into a question because it's not really truly proven. And then there is an unusual antidote, which is ticarcillin, which is another antimicrobial, but it forms a complex with gentamicin and other aminoglycosides that is then renally excreted. It's almost kind of like a chelator. The trouble is that it's very rarely used because by the time you figure out that they've got ototoxicity and nephrotoxicity, the aminoglycoside is often at very low concentrations, and so it's not necessary to. This is something we might consider using if, say, a nurse gives gentamicin to a child and then immediately recognizes it's a 10-fold dosing error. That is something that we might consider doing. So because it's unusual, because it's weird, I wanted to mention it just in case it comes up on an exam question, but it's not really standard of care. Okay, penicillins. You see the whole long list of penicillins up there. Luckily, they all end with cillin, so it's nice and easy to group them all together. The one thing I would remember about penicillins, obviously, as you all know, almost all overdoses cause nausea and vomiting, and that's completely non-specific. The key thing to remember about penicillins is seizures. Seizures almost never occur, and they occur only generally if you get a greater than 50 million unit IV over less than 8 hours. So this is going to be a massive error, or treating something super, super obscure. But I think it's a reasonable thing to remember, penicillin, seizures, 50 million units. How does it act? Penicillin, just in case you got a question on this, I think it's a little bit too obscure, but it binds to the picrotoxin binding site, which comes up with a lot of different medications as the cause of seizures. It blocks the GABA channel, and so your GABA chloride channel doesn't work, and you have seizures. But again, it takes a very, very large overdose, and oral overdoses would be extremely difficult to take enough to cause a seizure, so I wouldn't be too worried about that. Allergic reactions, of course, you can't say the word penicillin without talking about allergies. Pretty high risk of hypersensitivity, 5% of people. That said, as you all know, more people were told they have a penicillin allergy than actually have penicillin allergies, and there's been some interesting studies where they actually take people who say they have a penicillin allergy, just give them penicillin in an allergist's office, and very few of them actually respond. I personally was told by my allergist as a child to tell everyone I was allergic to penicillin, even though I'm not allergic to penicillin, which is kind of fascinating. The risk of a fatal reaction is quite low, but the risk of allergic reactions is quite high. So cephalosporins are very, very similar to penicillins. There's lots of generations. I don't think this is necessary to know or memorize, but of course, understand that we do group them into the different generations. We're up to 5th. 6th probably coming soon, I suspect. And that I think we all learned that cephalosporins have a cross-reactivity with penicillin. That was only the 1st and 2nd generations, and the cross-reactivity is extremely small. In fact, it's highly questionable whether it exists at all. It turns out that people who are allergic to stuff are allergic to other stuff too. So, if you have a 1%, if you're allergic to penicillin and you have a 1% chance of cephalosporins, you're probably just an allergic person. You probably also have a 1% chance of being allergic to erythromycin. So I wouldn't put too much stock in that. Cephalosporins, the same thing. You take an oral overdose, it's going to be mostly nausea, vomiting, and that's it. If you get way too much IV, seizures are possible. It's a couple of other unusual things that I kind of like group penicillin and cephalosporins together. Acute oral overdoses usually do just fine. A huge IV overdoses, maybe seizures. But there's a couple of unusual things with cephalosporins that I think are reasonable to mention, both from a clinical standpoint and from a potential test standpoint. One is some of them cause a disulfiram reaction. The disulfiram reaction is associated with this side chain called NMTT. The NMTT gets cleaved off and inhibits aldehyde dehydrogenase. So the list is there. They're not the most common cephalosporins, but certainly are being used. So, whether you want to memorize which ones, I don't know that that's necessary, but just, I think, remembering that some of the cephalosporins cause a disulfiram reaction. And sorry, I just skipped over disulfiram reactions. So disulfiram reaction is when something inhibits aldehyde dehydrogenase and you drink alcohol, alcohol gets broken down into an aldehyde and then can't be broken down by aldehyde dehydrogenase. The aldehyde then accumulates and you get a flushing reaction, which is normally not, most of these reactions are pretty mild, but if you keep drinking or if you're unlucky, then the aldehyde accumulates a lot. You get hypotension, wheezing, and there are a couple of deaths associated with it, but it's extremely rare. So, and then I think the other thing that is much more common than we thought it was before is cefepime encephalopathy. We just had a case a couple of months ago, I think. This will be, cefepime's an IV medication, so it's going to be an in-hospital type of toxicity, but the patients get very, very confused. They look encephalopathic. They just look really, really confused. They don't typically get sleepy. They're awake, but don't make any sense. And it is a cefepime accumulation in the brain. The only thing that really is going to be used to treat it is just simply wait. Stop giving them cefepime, of course, and wait for it to resolve. And the symptoms resolve entirely. So it's not a permanent encephalopathy or a permanent neurologic damage. It is, often a little bit of because the patient obviously has an infection, so because they were given cefepime, and so there's often a search for meningitis and encephalitis, things like that, but it does resolve on its own. All right, so we're going to keep plugging along. I apologize that it's kind of a list, but again, I think the key is to kind of just associate a couple of these things with each of the antimicrobials. So the anti-malaria, putting them as anti-malarials, I think we all know that hydroxychloroquine is often used for a lot of other reasons, for anti-inflammatory properties, essentially. But all of these you can group together: quinine, chloroquine, hydroxychloroquine. These are pretty nasty overdoses. And if someone takes, say, a month's supply or something along those lines, they're going to get very, very sick. They kind of get everything. QRS widening, QT prolongation. They have intracellular shift of potassium. So it's not potassium loss, it's just a shift into the cells, but they will have a serum potassium that is low. It also has a sulfonylurea-like effect on the beta cells of the pancreas. So it will cause insulin release when there isn't hyperglycemia. And so you can get hypoglycemia. And then oto and retinal toxicity, so eyes and ears. The EKGs often look terrible. For example, big wide QRS, long QT. Doesn't look like they're perfusing particularly well here. And this is from a case report that they had the after EKG and it looked, just like a normal EKG. So what do we do for these people? It's a little bit of an all hands on deck, but it all does make sense. So multi-dose activated charcoal can decrease the half-life, and so that these are enterohepatic recirculation. And so we use multi-dose activated charcoal not only to adsorb the drug when it's in the stomach, but also to increase its clearance. And then QRS, we give sodium bicarbonate a bolus. This is one of the cases with chloroquine where there is, just like with TCAs, there is pH-related protein binding. So it's a little different from TCAs in that TCAs mostly have pH related binding to the receptor. With the case of chloroquine, the protein binding gets, there's more protein binding at more alkaline pH. So if we give bicarbonate, we give the bolus for sodium to narrow the QRS, and then we give the infusion to increase the pH. The increased pH increases protein binding, which decreases the free chloroquine concentration, which then decreases the amount that's on the sodium channel. So it's a little bit of a different mechanism, but the same in the end, same results. QT, just like we talked about the last 2 days, without a Fab fragment, there's nothing to do about a drug-induced long QT. We always check our potassium, calcium, and mag and replete them up to high normal. And then the hypoglycemia is due to hyperinsulin. So insulin release, inappropriate insulin release. We should make it syndrome of inappropriate insulin release, sir. And that can be treated with octreotide just like a sulfonylurea can. So I think, what I would do is first hypoglycemic episode, just give dextrose. And if they wake up, give them food. If they have a second hypoglycemic episode, dextrose plus octreotide to kind of take that off the table. You got enough to worry about. Like most of toxicology, the drug of choice for ventricular dysrhythmias is lidocaine. That will both treat the ventricular dysrhythmia. It'll also narrow the QRS for the reasons I mentioned yesterday. It is a fast on, fast off sodium channel blocker, and so it will displace the antimalarial from the sodium channel. So you can actually give lidocaine and watch the QRS narrow. It's not our first line. We usually give bicarb, but it can be done. And in fact, I think we had a case, I think it was hydroxychloroquine a couple of months ago. And I know Nick Matzler told me about it, where they had given, I think, 4 amps of bicarb. The QRS didn't narrow, and then they ended up giving a lidocaine infusion, and the QRS narrowed with lidocaine. So it does actually happen every once in a while. Now, chloroquine has this this sort of extra special treatment protocol that we would probably bring up with any treating clinician. If you have a really sick chloroquine overdose, this is chloroquine specific. This is the protocol they used in this study. There's some issues with the study, but it's pretty good. The mortality before they used this protocol was 91%. The mortality after this protocol was 9%. Even with trouble with the study, that's a pretty big decrease. It's about as big as it ever gets, right? So this is one of those things that this is the protocol that they said. I will tell you how I interpret this, but I think there could be a question about chloroquine asking about, high dose epinephrine and diazepam as a treatment, specific treatment for chloroquine. So that's the answer on a test is epinephrine and diazepam, both at very high doses. I think clinically what we do is we don't care so much that it's diazepam that they're sedating them, but heavy sedation. So intubate them and then sedate them so that they're not moving anymore. Whether that's propofol or diazepam, I don't know that it really makes a difference. And then epinephrine, titrate up to pretty high doses. In the study, they just went to high doses immediately and kept it there. So, but we would use that as sort of the pressor of choice for blood pressure and heart rate. But again, I think if there's a question on chloroquine, there could, of course, be Yeah, none. So there's no study on this. Is one study. It's published in the New England Journal 35 years ago, and nobody sees enough chloroquine or hydroxychloroquine patients in an individual hospital to have accumulated enough to actually publish what the mortality is now. I have no idea. And for hydroxychloroquine, we don't know if this would work or not. So, and there's kind of no one's ever actually done it to suggest that they would be that it would be better. Yeah, I agree though. We don't see chloroquine very much. In fact, almost ever we see hydroxychloroquine. Okay, the floxins or the fluoroquinolones. Most of these are just fine. The one thing I would say is that Cipro, it is possible, not probable, but possible to develop seizures. And that is due to inhibition of GABA. This would have to be an absolutely enormous overdose. And I've never heard of it happening, but it has been described in a couple of case reports. So that's why I'm bringing it up. It's the exception in the fluoroquinolone group that most of the time oral overdoses don't cause anything at all. Now, on the other hand, chronic use of fluoroquinolones has been associated with QT prolongation. It's not really, we don't see this in acute overdoses. And I'm sure you have all heard this before, that it's associated with tendon rupture, and in particular Achilles tendon rupture. Honestly, there was a pretty big, actually a huge study looking at this in the last year or so, sort of disproving it and suggesting that people who take fluoroquinolones don't have an increased risk, but it's been in our textbooks for decades now. So if there's a question, then Achilles tendon rupture is the answer. Okay, macrolides. So once again, this is another case where the oral overdose, they get diarrhea with 3 R's, I see. Sorry about the typo. They will just get vomiting diarrhea. They usually do quite well. Large IV overdoses can lead to QT prolongation and has led to torsades. Again, I think that this would be tenfold dosing error in a child would be the more typical, not a oops, I rounded up. It has a pretty good therapeutic window, but a big dosing error can certainly lead to acutely prolonged QTC. And then, of course, these medications have lots and lots of adverse interactions. So I listed a couple here. They're kind of old school drugs, most of their interactions. Obviously, there's other interactions that can happen, but these are sort of the classics: warfarin, carbamazepine, cyclosporin, cisapride. They all can lead to accumulation of erythromycin or any of these, and a prolongation of the QT with potential for torsades. So there are many interactions with erythra. The answer is always long QT, though. If it's erythromycin or any of the macrolides and an interaction, the answer is going to be long QT. All right. Similar to, vancomycin, so oral overdose, very well tolerated, poorly absorbed. That's kind of how it's used orally. The IV overdose can lead to acute kidney injury. This is very similar to gentamicin. Either a very large overdose by accident, tenfold dosing error in a child, or a infusion that is too large for a period of time. The toxicity is acute kidney injury, so we have had cases where they're on a vanco infusion for days and days and days for some terrible infection where they're on 4 different antibiotics, and then they get acute kidney injury, and it's likely from the vancomycin. You get a trough concentration that's extremely high. There are two things we can do. Multi-dose charcoal might decrease the half-life, might increase clearance. But if they're really having acute kidney injury and they're very high vancomycin concentrations, you can do hemodialysis to remove the vancomycin. So again, these are all iatrogenic, no, not a home call by any stretch. All right, isoniazid, an obviously medication used for tuberculosis. The anti-tuberculous drugs, it's a very, very long list of them. This is the only one that was listed in the review list, but I think it's the one that we probably need to know about. The rest are things we can probably look up and it won't test on. Isoniazid, doses over 20 milligrams per kilo will produce seizures. I put the information there on what happens. It inhibits the conversion, pyridoxine phosphokinase that it inhibits, which inhibits the conversion of pyridoxine to pyridoxal 5-phosphate, which inhibits the production of GABA. So you're not making any more GABA. It doesn't bind to GABA channels. You're just not making any GABA, and that leads to seizures. The seizures lead to hyperlactatemia and metabolic acidosis. So it's not an uncoupling of oxidative phosphorylation or any of those other things. It is the seizure. So it's the flexion of the muscles, essentially, that's causing the lactic acidosis. We know this because there are animal studies where they gave them isoniazid and then gave them, like a cisatracurium or pancuronium to paralyze them, and they had EEGs and they were seizing, but they did not develop metabolic acidosis or hyperlactatemia. So it is the movements that is causing the hyperlactatemia. So if they haven't seized, they won't have a high lactate. If they have seized, that's why their lactate is high. So there's some chronic toxicities that are fair game for isoniazid. Neuropathy and hepatotoxicity. I always remembered INH, isoniazid, neuropathy, hepatotoxicity. I recognize there are other N's and H's that you might get confused, but that's the mnemonic I use. So the neuropathy is peripheral, kind of traditional toxin, stocking gloves, tingling and sensory. The hepatotoxicity is due to it being broken down into hydrazine, and that causes the hepatotoxicity. But both of these associated with chronic use, not with acute overdose. Acute overdose, seizures, hyperlactatemia, and metabolic acidosis. Okay, so what if someone takes isoniazid? Isoniazid, very rapid onset of seizures, usually within the first 2 hours, but certainly after 6 hours of observation, if they haven't had a seizure, they're not going to have any seizures. If they develop seizures, remember that without a seizure, they're not going to have hyperlactatemia, so we can't use that as a screening tool. If they do have seizures, the answer is pyridoxine. The empiric dose is 5 grams over 10 minutes. I think that's, or 70 milligrams per kilogram IV in kids. This is a good, one of those good cases where they assumed that adults were 70 kilos, which is obviously not true. Average American is 84, but if you just use that math, that's sort of how I remember it. If you just use 70 kilos, then 70 milligrams per kilogram for a 70 kilo person is almost 5 grams, and you get that number. You can use benzos, they may work. Remember, the problem is you're not producing much GABA, so it probably won't work very effectively, but certainly while you're waiting for pyridoxine to show up at the bedside or someone to find it, then benzos would be my first choice, and sometimes they do work depending on how severe the toxicity is. So I'm not sure how many doses are in there, but I feel like antidote doses are fair game, right? So 5 grams pyridoxine. And then on my list of like weird things to just pop into your brain, I mentioned this yesterday when we talked about serotonin toxicity, oddly enough, under the SSRIs. But linezolid is a specific antibiotic, not very commonly used, but is a monoamine oxidase inhibitor. And if you have to have another drug present, like you have to be on an SSRI and then they start linezolid, but it can lead to serotonin toxicity. So I think that's the one I would kind of keep. That's the association I would keep in my brain. So linezolid, monoamine oxidase inhibitor, serotonin toxicity. And we talked about a whole bunch of other serotonin toxicity causes yesterday. Okay, let me pause and see if there's questions. I have a lot today. I have like 3 30 to 45-minute talks. So yeah, the linezolid thing, it's kind of like fentanyl. We often say like, oh yeah, you can't give fentanyl to someone on an SSRI in the ICU, and yet people do it all the time at very high doses and they're just fine, right? So I think that there is probably a predisposition. The people who are getting serotonin toxicity are either getting high doses of linezolid, more likely they're getting very high doses of multiple other things that are causing serotonin toxicity, and then linezolid might be the straw that broke the camel's back, so to speak. And I think we often will say like you can't give certain, like I said, avoid linezolid, avoid fentanyl, but there are times when that's the only antibiotic that's going to work, and I personally wouldn't not use it because there's a chance that it might cause serotonin toxicity. So, though on the other hand, most of the ICU patients, they probably aren't getting their SSRI while they're critically ill, but maybe they are, maybe they're not quite critically ill. All right. Questions on this or any other antimicrobial that I didn't cover? All right. We'll move on then to what am I supposed to do next?